this longitudinal lesion of the posterior horn of the lateral meniscus. It's a grade 3 lesion with a complete rupture of the ACL. In the axial view, we can see here this longitudinal lesion. It measured 1.2 centimeter in length. So we confirm in arthroscopy the complete structure of the ACL. We confirm lateral meniscus, and it's slightly medially to the popliteal hiatus. So our decision is to make an all-inside repair with implant. So this is the popliteal hiatus. Our first step is to freshen the lesion with rasp to promote and enhance chance of healing. We can use multiple rasps. So as we say, we performed all inside suture with implant, and I choose the sequence by ComMed to do this reparation. We cut the protection sleeve at 1.8 centimeter to protect the needle, and we in this image we can see that if we use the anterolateral portal to repair this lesion, the popliteal artery will be in danger. So we chose to use the anteromedial portal. The first step is to pierce the lesion with the needle until this protection sleeve touches the meniscus. And then we deploy the first implant by pushing the black trigger, pulling back the device, we have to check the good tension and of the implant. We make in blocked position of the free wheel, tensioning, and then we do the other side, piercing the other side of the lesion in the same way with the free wheel position, with a gentle pronosupination. At that point, we have to do 2 clockwise revolutions of the device with the rotating, then pushing the black trigger forward and pushing backward to deploy the second implant. And this is the first stitch. Lock the device, tensioning the thread to compress our lesion. Then, with the same manner, we perform the second stitch in the same way, doing the rotatory revolution, 2 moves, pushing forward the black trigger, pulling it, and then retrieve all the system and do the tension. And as we see here, this is the final aspect of our meniscal reparation. After the reparation, we perform ACL reconstruction, anatomic ACL reconstruction with patellar tendon. Postoperative rehabilitation protocol, we do not weight bearing for 6 weeks. It's our department protocol. Repair with this device. It's It's the reparation of all type of lesions except root lesions, and we can perform for the posterior half of the two meniscus. In this study published in Arthroscopy Journal in 2020, it's a cadaveric study, and in this paper, they use the use of anterolateral portal to do all inside between the device and the popliteal artery is 4.7 millimeters. So all inside repair for posterior horn of the lateral meniscus through the anterolateral portal is risky. And in this meta-analysis, we can see in this meta-analysis, we see that the rate is up. Is quicker for all inside reparation. So the all inside repair has become popular. It has the advantage
I think we lost the
we lost the connection with Saber.
Yes.
Saber, you can restart your presentation, please.
from the beginning.
No, to finish.
Okay.
We didn't
To
see
finish your presentation, please.
the last part.
Okay. You can see the presentation?
Yes. Go.
Okay. So I will continue. The all inside reparation has become popular. It does not require an assistant. It can perform without the need of additional incision, and it's quicker than for inside out repair. But we have to say that the learning curve is long and demanding, it's costly, and sometimes demoralizing because of some perioperative complications such as the implant cutout and the needle breakage. And thank you.
Okay, thank you. I suggest to move to the second presentation about all inside the device and then discuss them both, maybe? What do you
Yes, we
think?
can do that.
Yes.
Okay.
So,
Okay.
Dr. Salman, you can share
Yes.
your screen.
All good?
Yes.
Yes.
Okay. So hello everyone. Our case is about a 27-year-old male who had a sports accident in a football game with a history of a severe knee sprain for 6 months. And we can see on the X-ray and on the MRI a total rupture of the anterior cruciate ligament. And we have also a vertical tear in the posterior horn of the lateral meniscus. So we've decided to make to operate the patient to do all-in meniscal repair, then an ACL reconstruction. So we're going to see the tear here. We are in the lateral compartment. This is the vertical tear in the posterior horn of the lateral meniscus. It is partially unstable. It's extended over 2 centimeters in the maybe in the red zone. And it's connected to the femoral and tibial compartment. So the first step was to make a sharpening of the tear to enhance the postoperative healing of the meniscal tear repaired. There is multiple ways to do this, as we already saw with the first presentation. Second, we're going to measure the depth of the meniscus here in the posterior horn with a depth probe, as you can see here. So we're going to see it. Here, this is the depth probe. We're going to measure the depth of the meniscus to avoid vascular injury behind. Because we're going to make an all-inside suture, so to avoid vascular injury behind the posterior horn of the lateral meniscus. So then the next step, we can introduce this metal cannula, slotted cannula, which plays the role of a guide to the implant. And here we have the all-inside implant that we are going to use. It's a fast fix from Smith and Nephew. And we're going to make two horizontal stitches. So with this type of stitch, we have to take the two meniscal fragments, the articular and the capsular ones, in a horizontal way to make fewer or lesser stitches. This is the first take, and this is the second one. Then we have to compress the stitch to make compression on the knot and in the meniscal tear. This way. And then we have to just to cut the knot. So then this is the final aspect of the first stitch. So here it comes. And then we've made another stitch here. The same procedure. I'm going to run to the final aspect. So it's the same thing. Here we are compressing the second stitch, and here we're cutting the second knot, and here is the final aspect. So in our case, our patient had no weight bearing for 45 days. This is our habit in our department for lateral meniscus repair, and a range of motion of 0 and 90 degrees in the first 6 weeks. So is it a good technique, this all-in suture technique with a fast fix or one stitch? Yes, it's a quick procedure. It can decrease surgical time with no additional scars, so it can improve cosmesis, lower risk of neurologic pain and pain from stitches, lower risk of vascular injury, especially for the lateral meniscus repair, and it is an effective technique such as the inside out and the outside in terms of failure rate, clinical outcomes, and return to work. But this implant remains expensive. It needs several points with the single-use materials, so which augment the cost, especially for the double row configuration. It needs a long learning curve, and we can have some gags, especially with migration or implant breakage intra-articularly. For the stitch, was it a good stitch? So with the fast fix or with all-in suture, we can make horizontal or vertical stitches in these vertical meniscal tears. There is no papers for the biomechanic meniscal healing on clinical outcomes in the literatures to compare between these two stitches. But as we know that the horizontal ones need less stitches, so can lower the cost. But it has been reported that vertical stitches are stronger than the horizontal ones because they follow the orientation of the circumferential collagen fibers. In summary, meniscal repair has a favorable outcomes, especially when associated with an ACL reconstruction. All-inside technique, such like in or out-in, are an effective techniques in terms of clinical outcomes, postoperative clinical outcomes, tensile load, and tissue failure rate. For the all-in suture technique, especially for the one-stitch technique like the fast fix, the vertical stitches are stronger than the horizontal ones. Thank you.
Okay, thank you, Amin. So we saw the two techniques of all-inside repair with implants. I don't know if Dr. Lafram or Dr. Torbio have some maybe some remarks regarding the techniques.
The same remark for both Ahmed and Saber. Why do you do non-white bearing for 45 days for these longitudinal tears?
We usually make it for 3 weeks, but we are afraid of the failure.
And if you have radial tear, how long is your non-white bearing period? Is it the same?
Yes, it's the same, 6 weeks. It's just for safety. It doesn't go with the scientific recommendations nowadays, but it's just a safe decision, and for me, especially for the lateral compartment.
Okay.
Okay.
Is there any question?
I have a question. What if the needle breaks? What would you do next? In the first case.
In the first case,
Yeah.
I have to mention that we have to be gentle with the device.
Yeah.
And try not to go if we we feel any resistance, we have to check our procedure.
Uh-huh. Another question I would like to ask. You showed your cases. Are you always doing them in what zone? Are you doing the white zone, or are you ignoring it and doing it for all cases, the repair?
Usually in the lateral meniscus, I do. I can say that I do all lesions.
You do all lesions.
Yes.
And have you had similar results in all lesions?
No. No, the similar. But well, yes.
Both of you didn't mention the long-term results. Me, as an orthopedic surgeon, a general surgeon, I would like to have answers on certain points. When we are doing these repairs, your case and your colleague's case, what is the long-term result as compared to a partial meniscectomy? Are we benefiting the patient? What about the recurrence of symptoms? I would like the answer from the groups. I think maybe I'm unfair asking this question, but the question to be asked.
So
I would like to answer to ask Dr. Taboubi, what does he say?
What do you mean, Dr. Abdul? Do you ask about the long-term result of
long-term
the repairs?
results as far as degenerative arthritis? Are we preventing degenerative arthritis in these cases?
What we know is when we do a meniscectomy, we have 100% arthritis in
I
our
know,
patients.
100%, I agree. But what about these partial?
But when the meniscus are repaired, we have much lesser, and it is a cost-effective surgery. When we evaluate it in the term of cost, it is a cost-effective surgery.
Cost-effective.
We can make a lesser arthritis, or we have arthritis in a more longest time. And the other impact is when we do a repair, we have a better result on our ACL reconstruction. We can much more stabilization of the knee.
So I see. And you routinely repair the ACL if it's present at the same time?
Yes. We have to do it in the same surgery, yes.
You do it at the same surgery.
Okay.
Okay. Thank you very much.
I think that we have to move to the next presentation with Dr. Ben Omar. You see all inside with the suture passer.
Thank you very much. I can share my screen.
Yes, please.
Did you see my screen?
Yes.
Yes, we can.
Thank you, everybody. I thank the Sotcot to give me this opportunity to speak today about all-in meniscal repair without implants. It's an all-in technique with device inspired from shoulder arthroscopy, which permitted to make circumferential stitch on the both meniscal surface. The first case is a 24 years old man, football player, right knee injury in April 2023, knee pain, instability, and when in the exam, the knee will be stable with pain in medial compartment and positive McMurray in external rotation. The X-ray is normal, and we see on the MRI the complex lesion of the meniscus with bucket handle on the notch. And in this case, we decide to operate the patient. And it's a classic technique, but I make a high anterior approach to do a complete exploration of the knee, sometimes by cresting with accessory approach. We use thread, absorbable or not absorbable, with the self-passing suture device. We need a suture pusher, a needle, a pusher, and the thread grappling pliers. It's what we need to win the game of the repair. In the case, we explore the meniscus, complex tear, but handle with a radial tear in the posterior horn. So we make a little debridement to improve the enhance of the healing, and we start with the posterior stitch. We will be careful with the cartilage with this device. And when we make our stitch, we continue one by one. And with this technique, we can repair the longitudinal lesion, the radial lesion also. And for the anterior part of our meniscus, we complete with out-in technique. And so the aspect of our meniscus in the final of the repair with stable lesion with the stitch on the both surface of our meniscus. And we compare the aspects before and after the repair. In postoperative, the procedure depends of the lesion. In this case, no weight bearing for 4 weeks, 90 degrees of range of motion for 4 weeks, and sport after 7 months. We make an MRI 1 year after the surgery, and we see the modification of the signal of the meniscus with the meniscus in place. It's the sign of healing of our meniscus. Maybe after 1 year more, we can see a better aspect of our meniscus, and we will compare the signal of the meniscus before and after, and we see the difference. In the second case, it's a 51-year-old man, right? Knee injury in May 2019 with a knee, stable knee on the exams, a painful lateral compartment, and normal range of motion. Don't see osteoarthritis on the X-ray. So we make an MRI, and so we see a bucket handle lesion of the lateral meniscus. A complete lesion of the posterior part of the lateral meniscus with the aspect of double PCL. We see the double PCL aspect. The exploration in the same technique, our bucket handle, the lesion in front of the popliteal hiatus. And so we make a little debridement in the lesion. And so we do the same technique to repair. When we make this technique in front of the poplite, we can verify the point, the thread before making the second point. So we are sure we take the lesion and we can continue with the pusher. We used a PDS thread in this case also. The first point, first stitch. The second one. In the same technique, the same verification. We continue also. We need to be careful with the cartilage. It's very, very important to don't. And the final aspect of our repair with 4 stitch. And the compare, we can compare the aspect before and after the repair. This technique, it's fast and safe, adapted for all type of lesion. They don't do skin irritation and not additional incision. We can do it for the person like this. Comparing to repair with implant, our technique permits circumferential repair. It's more better in the literature to enhance the chance of healing. It's adapted to different type of tears. It's without vascular or neurologic damage and no complication due to the peak. It's also an ecologic and economic technique. We can do this repair for all type of lesion, radial tear of lateral meniscus. In this case, the same thing for horizontal tear also. It's possible. And we can repair all type of lesion. We need a learning curve, but this technique is so safe.
The X-ray looks normal.
Watch the area where the meniscus is the posterior third of the meniscus, and all the lesion situated 2 or 3 millimeters in front of the meniscal wall. What's the limits? We need to have the instrument, buying the suture passer, and the veritable limit is the tear in an anterior third part of the meniscus. In this case, we can combine with out-in technique. In the literature, this technique make good results, also the same or a little better results for healing and compared to all other techniques. Thank you very much.
Thank you, Dr. Ben Amr.
Thank you, Dr.
Thank you, Dr. Ben Amr. There is a
We have
question.
question.
Allez-y, Rafiq. Go, Rafiq.
Yes, thank you, Dr. Tberbi. There is a question in the chat. Dr. Yusuf Othman is asking, do you use smaller passer or the same in the shoulder suture?
It's a smaller one adapted for the knee. It's like a device for the shoulder, but more smaller. We can use sometimes the bigger one when we have a lesion in the 2 millimeters in front of the wall of the meniscus. In this case, we need to have a big grasper to have to use the bigger one, but it's a rare situation. It's not the habitual situation.
There is also another question from Ayman Zgoli. Do you use the thread number 1 PDS?
See, number
Other
1.
sutures.
See.
Okay,
Dr.
I have a
Papalia,
question.
Dr. Papalia, you have the power to open your mic if you can't speak.
what do you think of this technique? Maybe you can.
Yeah, it's a good technique. Congratulations for the results. It's very good. Aesthetically, it's very good. We have we will see the outcomes over the time. You know, the function, the knee. It depends of the structure of the meniscus that we have when we do this kind of a suture. But the procedure is very good. It's very nice.
Okay. So
Since Dr. Mamar, since you use the suture passer, what do you advise all the attendants about the safety of the cartilage? What we have to do to make the cartilage safe with such bigger one instruments use?
When it's when we make this technique, we need to turn 50 to 20 degrees the device before grasping. So the needle, when be out, don't damage the cartilage. It's and if we are in the posterior part of the meniscus, we need to push all the meniscus in the posterior part. The maximum push of the meniscus in the posterior to to be safe with the cartilage of the condyle.
Okay, thank you, Dr. Ben Omar. I think we have to go to the next speaker, and Dr. Nafis, if you are here.
You are hearing me?
Okay, you can go on.
You can see the presentation?
Yes, yes.
Okay.
Perfect.
Thank you, Hisham. We will continue with another option to preserve and save the meniscus, especially in such cases of bucket handle tear in a stable knee. So our case is about 28 years old, a football player with a right knee trauma during training 3 weeks ago. He stopped training because of 2 episodes of spontaneously resolving knee locking. On examination, he has knee pain and swelling. He has positive meniscus test and now no signs of sagittal or coronal laxity. You can see here the axial view, and on this axial view, you can see that we have an intact lateral meniscus. However, in the medial meniscus, we have this V sign of bucket handle tear. In the sagittal view, we can see also that we have an intact lateral meniscus. However, in the medial side, we have the aspect of double PCL, which is evocative of bucket handle technique. Finally, in the coronal view, we can see that we have this sign, which is an intercondylar notch sign. So we can go. We are in a case of bucket handle tear with different sides, the V sign, the double PCL sign, and the intercondylar notch. In a football player, what we are going to do on exploration, we have this aspect. The video is not working here. It will be okay with the other videos. So it's a fresh bucket handle tear. It's a reducible tear. So we have a lot of questions that we can ask in this case. How would you approach this injury? You can propose meniscectomy if you wanted to go back as fast as possible to sports. But if you want to save the knee of the patient, you can propose repair without augmentation or with augmentation. We can have questions. You can ask also about the technique of suture. You can use which technique is more suitable for such cases, and do I need devices to repair such injury, and how does it cost for the patient? We had seen different technique with using devices, using different tools, but in our department we opted for very old technique. In fact, it was described in 1980. It's the in-out technique, the inside-out technique, which is still useful technique. We have our variant in our department using this needle, and we published this paper published by Dr. Anis Borbi. It's an economic technique. It's an efficient technique. We need for this technique an accessory incision in the medial side for this bucket handle of the medial meniscus. why some video doesn't work. So this medial incision, the role of this medial incision is to protect soft tissue, and we can put a spoon in this triangle region just behind the medial capsule, posteromedial capsule, and in front of the medial gastrocnemius. The base of this triangle is the semimembranous tendon. The anatomy of the incision is well described in the literature and in our paper. I think I will move to the other laptop, because here I don't know why the quick time doesn't work here. So please, Qatar Aziz, you can accept. You can accept me from the other laptop, please.
But you have to leave this. You have to leave this sharing screen.
Yeah, he's accepting.
And share this screen and share the other one.
Muad, I can put you the video and you comment if you want. From my laptop.
Is it okay?
Yes, perfect.
Yes.
Okay. So we were just here.
Can you put the full screen if you can?
Yeah, okay. Just 1 minute. Is it okay?
Yes, perfect.
Yes.
So we said that the anatomy of this accessory approach is well described in the literature as well as in our paper. So the elementary point is that point. We will use this needle and we will introduce it in one side of the lesion. Then we will pass the suture to this. We will take it from our incision. The second step, we will go back and we will do another passage to do this first elementary point, which is a vertical point. We will retrieve our suture from our incision with soft tissue protected with the spoon. And the job is done. It's the elementary point, which is very important to reduce our tear and especially to fix our meniscus, our dislocated meniscus. And you see that this point is well applicated against the capsule compared to the other technique where we are not a good fixation. We are not sure about our fixation against our capsule. Once the dislocated meniscus is fixed, we can do as much as we want from the posterior part to the anterior part. In sometimes we cannot reach maybe the most posterior part or the most interior part, so we can add the other technique, the out-in technique or the in technique. And once we have sometimes this kind of deformity of the meniscus, we need to add sutures in the tibial edge to press our meniscus against the tibial plateau. And here the final aspect of this bucket handle repaired. So the advantage of this technique, it's a technique compared to all the technique. We don't need a device to pass the passer used by Dr. Ben Amour. We don't need the fast fix or expensive devices. It's an efficient technique since we press our suture against the capsule, and we are sure about that. So for such cases of bucket handle in unstable knees, where the risk of recurrence is very important, we advise to use this technique. And thank you.
Thank you, Dr. Nfis. Do you have any remarks, Dr. Borby or Dr. Lafram?
There's a lot of questions in the chat.
Yes, there is question in the chat. They are asking, what do you do if the meniscus is not reductible?
Yeah, there are some tips and tricks to mobilize the meniscus. Sometimes we can have some fibrosis in the anterior horn. We can just decompress it or liberate it, and then it will be reductible. I mean, we can reduce it.
I have a question for you, Moab.
Yeah. Yes.
In which position do you tie your knots? Do you put the knee? Do you tie your knots knee highly flexed or 90 degrees flexion, or?
Yeah, it's not that difficult with the medial meniscus, but it's a little bit difficult with the lateral meniscus. In medial in medial case, it's just flexed, yeah, with the knee flexed.
Okay, thank you.
I can say something, Muad.
Yes.
When we use this technique, when the approach is well done, the position of the knee is not a matter, because the knot is tight on the capsule. So you can tie it in flexion and in extension. There is any influence on the knot. It is a question that is recurrent, but on the medial side, we can do it in full extension to prevent flexion. But when the approach is well done, it's not important.
Thank you,
I
Dr.
have a question, Dr. Tuberbi. For a bucket handle lesion of the meniscus, how many stitches do you make? The minimum to make sure that the meniscus will have the great chance to heal.
I can't answer, but we put as we need. We put knots every 5 to 7 millimeters. Sometimes we put 8 knots, but sometimes we can put 20 knots. It depends.
I mean, how many? Every 5 millimeters?
Every 7 to 5 millimeters, yes. And on both sides, on femoral and tibial side, to reduce the meniscus and to make a seal to prevent articular liquid to pass through the tear.
Okay. There is a question in the chat from Dr. Othman. Do you think that general anesthesia is necessary for meniscal repair?
It's much easier to do with good relaxation, especially on the lateral meniscus. Because on the medial meniscus, when you use picot sting, it is always easy to do. For the tight lateral meniscus, it's a very tricky surgery. I don't know if Dr. Rocco Papalia have a solution for the tight lateral meniscus, the tight lateral side of the knee.
Dr. Rocco?
Dr. Papalia?
For the lateral meniscus, we use the position without stress. and with I think that the anesthesia is very important for the lateral meniscus. And then I agree with you.
Do you use some artifice like resting on the lateral side or osteotomy of the lateral epicondyle, or it's too much aggressive for repair?
No, it's too much aggressive. I don't use it.
And Dr. Torbi, for this type of lesions, do you give full weight bearing directly, or you wait
for longitudinal tears, we can give full weight bearing. The problem with these tears is deflection. In our department, for this patient, we can give them weight bearing as soon as possible, and for deflection, we permit them to go to 60 degrees for the next 3 weeks, 90 degrees the 3 weeks after, and above 90 weeks after 6 weeks.
Yeah.
Okay.
I agree.
Okay.
And I will ask a question if you allow me to do it as an old general orthopedic surgeon. What about football players who wants to recover quickly and go back to sports activity, and comparing to meniscal resection, what meniscectomy, and they will have 6 weeks without weight bearing, and they will stop sports activity. It's not very appreciated by the professional football teams. What do you think about that, Dr. Papalia? In Italy, in calcio, you have
with the calcio, we have a lot of problem with with football teams. Also with as well as in my colleagues in Premier League. The problem is that the players wants the meniscectomy. More for the medial meniscus. Now the problem with the lateral meniscus is different, because lateral meniscus heals very well, and the time to return to play is not so long as before. But for the medial meniscus, they prefer the meniscectomy.
And when you discuss with them the possibility to repair the meniscus,
of course, every time, but you have the football team that push a lot for a rapid solution, and then the players doesn't care about the knee, about the knee function over the time, because they want to go to play as soon as possible, and then it's very difficult to obtain, to have a meniscal repair, and to stay without playing for 3 months for this kind of players.
Can I ask the same question and the point of view to Dr. Torbi, Dr. Ben Amor?
I think if there is an ACL tear, there is no problem. We can repair as we when we want. The problem is when there is medial tear on the stable knee. Medial tear on the stable knee, football never accept the repair, so we go for the resection in many times, and we have to struggle when there is a lateral bucket handle tear, because we have to repair it every time. We can do medial meniscectomy, but we can never do a lateral meniscectomy. We have to convince the player to save their lateral meniscus, and this is the problem. We have to struggle with players to conserve their lateral meniscus.
Yeah.
we try to convince the player to accept the repair, but a lot of time they don't accept because a long time of no playing, it's a long month. Okay, like Anis, when we have an ACL tear, the problem is clear. It's the same time to recovery for the meniscus and the ACL reconstruction. But for stable knee, the problem is really, and for the medial meniscus, it's the same attitude. Meniscectomy, the meniscus will be go in the trash. But for the lateral meniscus, the problem is different. And I see in the last years, the player will be accepted more the repair than before.
Okay, thank you. I think that we have to move forward
You
for the
have a
next
question. You have
presentation.
also a question from Dr. Mustafa Al-Fadri. I don't know if you want to answer now. In the chat box, don't forget it.
Yes. I think that we have to keep it for the end because it's a general.
After the next presentation or for the end.
Yes. It's a general question about so let's move forward and we will answer him later. We move to Dr. Busrih.
Yes,
He
thank
now
you,
prepare
Hisham.
with augmentation.
So, do you see my screen?
Yes.
Okay. Okay, thank you. So in this presentation, I will demonstrate the technique of the fiber and cloth augmented repair. So our case is a 26-year-old man, an active soccer player. He has a history of left knee pain since 1 year. Without instability, knee deformity. Donc, in the physical exam, he has a full range of motion, a negative Lachman sign, and a medial joint line tenderness. In the MRI and coronal view, we see this large horizontal cleavage of the posterior horn of the medial meniscus with the parameniscal cyst. In the sagittal view, the lesion reach the femoral side of the meniscus, but not the tibial side. So in arthroscopic funding, show a normal ACL. After picroresting of MCL, we are able to visualize the lesion. There are a large femoral side opening of the lesion, but not the tibial side. So putting the probe inside the lesion, we can evacuate the cyst liquid. As the first step of the treatment, the lesion was aggressively abrased with a mechanical shiver. And after, we decide to prepare the fiber and cloth. So to prepare the fiber and cloth, we use between 20 and 15 milliliters of peripheral venous blood from the patient. The blood is put in the sterile glass, and a plastic syringe is used to stir the blood with a regular rotatory movement, like this. So this cloth has to be washed numerous times with the saline solution until it becomes clear. So The fact of reeling the cloth into serial compress gives it a fibrillar aspect. When we have a large longitudinal tears like bucket handles or horizontal tears, the cloth has to be long to cover the whole lesion. So a shuttle suture thread is used to transport the cloth inside the knee. We use the vicral one suture with multiple knots to prevent the cloth from slipping. This is how we fix the cloth to the shuttle suture thread. A multiple knot can be used. This way, we have a good fixation of the fiber and cloth, making it easy to manipulate inside the knee. So we use many knot. So in case of radial or oblique or a small lesion like our case, we can keep the cloth in its circular form. We will just fix the subtle suture thread of the cloth. So then the cloth has to go in one block inside the knee without being lost within the Hoffa fat. So for this purpose, we use a sterile tube to pass the threads inside the knee in buttons of the lesion. Thus, so in our case, we use the in-out technique using PDS1 threads. The PDS threads is used to track the vicral already fixed of the fibrin cloth. Afterward, we track the vicral threads, allowing the cloth to enter slowly the knee until it reaches the meniscal tear. So during this step, the irrigation is stopped to facilitate the passage of the cloth and to stay inside the tear. We use afterwards our preferred technique for meniscal repair, described by Dr. Nfis, which is the in-out technique. It allows us to make a many vertical knot as we need on the femoral and the tibial side of the lesion. It also cost-effective. And this is the final aspect of the repair. So the post-operative protocol is same as standard in-out meniscal repair. We all allow early weight bearing for our patient using to crouch. We authorize the return to sport after 4 months post-operative. So a failure rate in isolated meniscal repair can reach 25%, according to the recent review by Zeffigini. In order to reduce this failure rate, multiple biological augmentation technique were used. One of the technique we can use the fiber and cloth augmented meniscal repair, with which the healing rate can reach 90%. This technique can be used in a large longitudinal meniscal tear, in a radial tear, in a horizontal tear, and a meniscal cyst and parobic tear, especially with a stable knee. So in conclusion, It is a cost-effective but a demanding technique. It can be helpful for meniscal healing of low potential healing lesion, but we need further follow-up for our patient and more study to confirm effectiveness. And thank you.
Okay, thank you, Anis.
Thank you very much.
I have a question for Dr. Tborbi. What is your specific indication for this type of augmented repair?
We do augmented repair mainly for meniscal repair on a stable knee, and when we have to reduce the failure risk as much as possible, especially in the radial tears, horizontal tears, or a large bucket handle. But it is a time-consuming technique, and there is a learning curve, to do to dominate the technique.
Okay, thank you. Dr. Papalia, do you use this technique? Maybe?
No, I don't use this technique because we prefer to do any microfracture to enhance the healing on the condyle wall anteriorly to the ACL, and in this way you can produce a bleeding from into the joint that is very useful for isolated meniscal lesion, like in this way.
So marrow venting technique.
Yeah.
Yes.
Okay. We can go for the next presentation.
Okay. Thank you, Anis, and we will move forward to Dr. Papalia for his presentation.
Thank you very much for the possibility to speak in this important meeting with my friend. And then I had to speak about radial and the root tears of the menisci. And we start with a clinical case. And the first one is a male, 29 years.
If you can share,
We
you
can
share
see
your screen.
your screen, Dr. Papalia.
Okay. Now?
Yes, now we can see.
Okay. And then this is the first case, and male, 29 years, and trauma on the left knee, landing from a parachute jump, and ACL tear plus medial meniscal radial tear. And this is MRI in sagittal site, and you can see the lesion. Also, you can see in the medial aspect of the knee, and then we have to do a tear reconstruction plus radial tear repair, and first repair of the meniscus, and later the ACL reconstruction simultaneously, and we do the pie crusting of the MCL, and we use all inside self-retrieving device to pass a non-absorbable suture, high-strength suture, one for each limb of the lesion, and we do a single tibial tunnel using the pull-out technique. You can see the suture. Post and posteriorly, anteriorly, and now we do. Okay, this is the final results, and something about the technique. You can use this kind of technique for the medial meniscus, but Laprade described also the same technique without the pull-out of the tissue for the lateral meniscus, only with side-to-side repair. This is another case, is a male, 37 years, trauma right knee during recreational soccer. We have a ACL tear, lateral meniscus, horizontal plus posterior root tear. As you can see in MRI. And here we have the flap, and then we remove the flap as a partial meniscectomy, and then we do a horizontal tear repair using all inside technique, posteriorly and out like a bridge with a popliteus tendon, as you can see in the video. And then we do the root reinsertion using a pull-out technique with a transtibial technique. Okay. Clinical case 3. This is a female, left the knee pain after twisting her knee getting down from the car. A degenerative medial meniscus posterior root tear. You can see in MRI. For that, we do a technique of root repair using an anchor. The technical tips is using a portal medial portal as working portal, a anterolateral portal as viewing portal, modification of the G-steel maneuver, all suture double loaded 1.9 millimeter suture anchor, an all inside device using a curved hook right side for the left knee. And then we had a good result stabilizing the lesion. And then with and also the same technique using the transosseous repair, and we can choose also this kind of technique, but we think that every technique is high demanding for, but not for experienced surgeon. But there is some papers about the techniques ankle repair that we have a possible advantage: no further tunnels, less displacement after cycling loading, greater stiffness. And then there are two studies comparing the two techniques for posterior medial meniscal root. One reporting no difference, and another one reporting favors suture anchors. About the technique, we know that the two double log loop sutures have significantly higher failure loads compared with the others. For the rehab of all the cases, we use no weight bearing for 6 weeks, no flexion past 90 degrees for 6 weeks, deep weight bearing flexion after 3 to 6 months, return to sport after 6 months. If ACL reconstruction is performed simultaneously, follow a standardized ACL protocol with the previous modification. Thank you very much.
Thank you, Dr. Papaglia. It's interesting to see the suture anchor technique because I think we don't have any experience of it here in Tunisia.
Si Dr Ben Amour l'utilise, la réinsertion.
Okay.
A question for Dr. Papalia. How do you choose either technique or either to use pull out or repairing on an anchor? Which character, on which parameter you choose the technique?
Yeah, I depends of the also the medial aspect of the knee. If I have a good space, I prefer the anchor because the anchor is very easy to do using a medial portal. But if you do ACL reconstruction, then there are two things. One is the medial aspect, and then how much you can open the medial aspect. Another thing is if ACL reconstruction, you have to do simultaneously the ACL reconstruction. I prefer anchor to avoid another tunnel. Okay, and then I do the anchor for the root and the tunnel only for the ACL reconstruction. Then, if you have isolated meniscus, I prefer to drill a tunnel.
Okay.
Do you have
Go
any
for-
other questions? Maybe.
Go for the next presentation.
Okay. It's your turn, Dr. Burbi.
Okay. You can stop sharing, Dr. Papalia.
Yeah.
When I chose my patient for the root tear, I chose the an old patient, 62 years, but Dr. Papalia repaired a root for 76
72
years.
years.
Depends on the cartilage,
Yes. First of all, it is the presentation of Mahdi Ben Ayed. He did the work, but he has his chief introduced him to do the presentation. So I did it for him. In our case, he did 62-year-old male, active smoker. He have left knee trauma 6 months ago. He has mechanical pain and the failure of the conservative treatment. On clinical examination, he has a Geneva-Rome deformity on both sides, middle joint line pain, and no laxity. And these are his X-rays. There is no osteoarthritis. A good knee for a 62-year-old male. It is his pangonogram with 8 degree of virus on the left side. And for this patient, we did an MRI. This is the MRI. And we see here the extrusion, a significant extrusion of his medial meniscus. And when we go with the slides, we see here the root of the avulsed root, posterior medial root. On the sagittal plane, you have ghost sign, which is evident here. There is no meniscus here. And on the axial views, we see very well the tear, which is here. So in our case, we have a 62-year-old male with no osteoarthritis, 80 degree of varus, with a failed conservative treatment. For this patient, we choose to go for a scope. And this is the scope. We have a type 2 posteromedial root tear. And when we see on the medial gutter, we see the extrusion, which is dynamic. When we compress the knee, we have an extrusion of his medial meniscus, which is very significant. Is superior than 3 millimeters of extrusion. So for our root, we do only one technique. We do a transtibial pull-out technique. First, we prepare the insertion site with the curette. Then, using the ACL aimer, we pass the pin in the center of the prepared footprint. Then we do a 4.5 tunnel. Next, we use the hook to pass the threads. We use 2 lasso loops with non-resorbable 2 Etimod. This is the first one. The lasso loop gives a good grip. Then we put a second one. Then we retrieve these 2 lasso loops through the tibial tunnel, and we fix them on the mini plate. This is the shuttle with the PDS. We retrieve it on the medial portal, and we pass them through the tunnel. And this is the final aspect of the repair. For our patient, he has 62-year-old, and he has 8 degrees of varus. We choose to add a high tibial osteotomy. We put the osteotomy just below to the entry of the tunnel, and we pay attention to put our screw on either side of the tunnel. And this is the final X-ray of the patient. On the post of rehabilitation, we use a non-weight bearing for 6 weeks. A passive range motion is started still from day 1, and we stop at 90 degrees. When we see at the bibliography for this type of the tear as the root tear, when we compare repair versus meniscectomy versus non-operative management, it seems that repair is a cost-saving intervention, and it is the preferred choice to treat this type of tear. How do we repair this tear? Using anchor or pull-out. The outcome is the same for pull-out or for anchor, but pull-out is more accurate and more reproducible technique. Do we have to add some other surgery for this repair? When we add high tibial osteotomy, we improve our healing rate of the posterior root of the medial meniscus, but the outcome is the same. Some surgeons start to speak about recentralization. We don't have experience with this technique. This technique attempt to recentralize the meniscus and to prevent a secondary extrusion after a meniscal root. And for my conclusion, I will show a small case. This is a 65-year-old female, knee trauma, 19 September 23. She was painful, and these are her X-ray in the moment of trauma. We see Madame Afifa, 19/9/23. For her, we did a conservative treatment, and we saw her at 18 June 24, 9 months after, and we see her medial condyle. She developed a medial necrosis of her medial condyle. For this patient, we go for a total knee, and when we saw his meniscus, it was a misdiagnosed posteromedial root tear. So the conclusion, we have to consider this tear in every patient, mainly in female around the 50 years with knee trauma. We have to diagnose these tears very quickly to repair them to avoid this sad evolution. Thank you.
Thank you, Dr. Dworbi, for your presentation and for showing us the importance of root tear repair, even if the age of the patient is high. Dr. Lafram, do you have something?
Yes. Dr. Dworbi, do you advise us if we have 50 or 60 years old patient with the knee trauma and normal X-ray? Do you have to perform an MRI of the knee?
I think if the X-ray are normal and if the patient is still painful, you have to do an MRI.
We have some questions in the chat. Maybe we can.
Yes, we have a question pending. What are the key factors to determine the success of the failure of the meniscus repair, and how we can we optimize outcomes? Dr. Burbi, Dr. Papalia.
Should I respond? There is many factors to consider, and I think the most important factor is the technical factor. We have to respect the technical imperative for a good repair, starting from the choice of the patient, the good indication, then the good surgery. And even with respecting that, we have mainly 20% of failure risk. 20 to 15% of failure risk.
Dr. Papalia?
Yeah, I agree. And I add that also the time from the trauma to the surgery is very important. The rehabilitation protocol, the number of the suture that you use, because the tissue is it's a tissue already with the trauma from and then you have to put only the suture that are very important for the success of the surgery. And it's very important also if the meniscal repair is simultaneously of ACL reconstruction, because the results are better.
Thank you.
There is a question from Rebhi Saber. What do you do in irreducible root tips? And is there difference using resorbable or non-resorbable threads? Dr. Papalia, what do you think? Do you use non-resorbable threads in roots?
No, I use no resorbable.
No resorbable.
Only no resorbable. Yeah, because I think it's very important to use not resorbable for the results. Yeah, I have a comment also for the centralization. Yes. We use the centralization in Italy. If the extrusion, if there is extrusion of the meniscus when after the root repair, and in this case we do a centralization with the anchor in the mid body of the meniscus. It's very, very useful.
Okay. Oh, do you use a metallic anchor or all shooter anchor?
Shooter anchor.
Shooter anchor.
All shooter anchor, yeah.
May I ask a few questions?
Yes, of course.
Okay. Look, I'm a common orthopedic surgeon, humble like Remzi Bouzidi. Now, there are questions that we would like to know about. Number one, how often do you go in and have a second look to see your results? Number two, what is the failure rate? Number three, what about comparing these results over time with the simple partial meniscectomy? And number four, what would you do if you find that the knee is so tight and you cannot do an inside out or an inside technique? This is a point that many of my residents tell me that they have seen a case that they just couldn't go in, even with the best of anesthesia. And finally, number five, how often do you give up the procedure and do an open technique? And thank you very much. This was a very interesting conference. Thank you.
For the second look, Dr. Abdul Noor, we have the chance to do a thesis in our service, and in this thesis we did I think 2 or 3 second looks, and we have a very beautiful image of second look of complete healing. I think it was the thesis of Anis Bousriah. Is he with
And
us?
regardless of the type of tear?
There were mainly longitudinal tears. We have only 2 second look of roots, and we have also beautiful image of root healing. I think in our series we have approximately 10% of failure rate, and from this patient, I think of 2/3 of them we go for a second repair.
Thank you.
And for tight knees, on the medial side there is no problem. We have to use the trick of the pike resting, and it facilitates the procedure in all cases. The problem is on the lateral side. When we have a tight lateral side, it is a big problem. Sometimes we have to convert the patient for general anesthesia, and in our practice we have never gone for an open surgery in meniscal surgery.
I see. Do you consider now the lateral meniscus is far more important to repair than the medial?
Yes.
What's your rationale for it?
Lateral meniscectomy can affect the knee, and it is on the lateral side we have 2 convex surface, one against the other. That makes the role of the lateral meniscus very important. When we remove the meniscus, the stress on the cartilage is very important.
Anyway, whatever findings that you appear at a late stage, let's say after several years, do you think this is secondary? As I heard from the interesting speakers, that it's very important to do the repair early, not wait for some time. But you realize that the cartilage degeneration, could it be from the tear, or is it from the technique used by the surgeon being neglectful and I don't know. Another point is, what about the needle that is broken? What do you do then?
So we are doing surgery to prevent cartilage damage.
Well, let's say inexperienced man.
I saw when I was resident, I saw meniscectomy with the patient leaving the operating room with his arthrosis, with his osteoarthritis. But now I think the surgery is much more easy and much more codified, so we can do very complex procedure without any cartilaginous tear, iatrogenic tear.
How many cases should the resident do so as to consider him a good surgeon to be able to do it?
Good surgeon. I think till now I am not considering myself as a good surgeon for this surgery. It's very difficult surgery, and we have to do a lot to be confident with it. Sometimes we have mainly on the lateral side we have some difficult cases.
Thank you very much.
Okay, thank you. I think that we have to move to the last presentation about ramp lesion, and it's Dr. Benabid. You can go.
Thank you, Hisham. Do you screen?
Yes. You can put the full screen. Yes, good.
Okay, we are now moving on for the last case. It's a 20-year-old man who is a recreational football player who had a football accident 4 weeks ago and who is now complaining of knee instability and posteromedial knee pain. He has full range of motion, eccentricity of quadriceps, has a positive Lachman, pivot shift, and anterior driver test. So on his imaging, we can notice that he has an ACL tear, has a hypersignal in the posterior horn of the medial meniscus, and bone edema in the posterior part of the medial tibial plateau. So he has ACL and a very probable medial ramp lesion. So our surgical planning was to make an anterior knee exploration and then to put the scope in the notch to see the ramp, and make our ramp repair by the posterior medial approach, a hook technique described by Morgan in 1991, and then construction. By shaping the horn of the medial, which is hypermobile, stable, and then we go part of the knee in not style cruciate ligament, direct visualization of our ramp. When we are there, we have to make our posterior medial portal, so it has to be close to the meniscus to have a direction of the instrumental portal parallel to the posterior horn of the medial meniscus, which is better for our repair. So we did medial portal, and then we get our ramp lesion that we have to freshen with an arthroscopic rasp. You can also do it with an arthroscopic shaver. We do that to have a rate of healing of the. In that case,
We don't hear you. We lost.
Stop your camera, Ahmed Ben Abid.
Yeah.
We are
Ahmed,
not hearing you, Dr. Benabi.
we are not hearing you. Call him.
Yes, I'm calling. He's not.
Dr. Benabi, I forced the sharing screen because we are not hearing you. Could you repeat, please?
We are not hearing. We are not hearing. Can you? From the beginning? Yes. Not from the beginning, but from the video.
No, with the video.
Okay.
are you hearing me?
Yes.
Stop your camera is better, Ahmed. Stop your camera. It will be better for the net, for the internet.
Okay. I'll stop my camera right now. So, all the video we didn't see.
After the trans notch.
So, okay. No. So when we visualize our lesion, we have to freshen it with an arthroscopic rasp. You can also do it with an arthroscopic shaver to have a better rate of healing of our lesion. And as you see it, our lesion is located between the wall of the posterior horn of the medial meniscus and the posterior capsula, which is the capsulomeniscal junction meniscal ramp lesion, which is a type 1 ramp lesion from the classification of Bertrand-Sonnery-Coté. And we can now start our repair with a hook by biting the capsular side, and we're going to pass a PDS shuttle through the capsular side that we're going to retrieve with an arthroscopic forceps from the posterior medial portal. And then we use our shuttle to pass a non-resorbable suture on the capsular side. And then we're going to do the same thing on the meniscal side, passing the shuttle, the PDS shuttle, that we retrieve and use to pass our non-resorbable thread on the second side. We have now to check the quality of our reduction to better face the two banks of the lesion for a better healing and to have an anatomical reduction. And then we have to tie our knot to finally stabilize our lesion. And we tie our knot with the knot pusher. We cut the thread, and then this is the final aspect of our ramp lesion, which is reduced and stable. And we can go now for our ACL reconstruction, which is not the topic of our presentation today, so we are not gonna describe it. So for postoperative care, we gave him immediate active and passive mobilization, had no weight bearing during 3 weeks, partial from week 3 to 6, and total weight bearing after 6 weeks. The flexion was limited to 90 degrees for 6 weeks, and except that he had a standard ACL rehabilitation protocol. It's like it's said in the literature, except the fact that in most of the publication, they give total weight bearing after 3 weeks. We can see in the literature that ramp lesions are very, very frequent. They are present in almost 40% of all ACL tears, and 20% of ACL tears are accompanied with unstable ramp lesions. The problem is that the MRI sensitivity is sometimes low for detecting that kind of ramp lesions, so they recommend in the literature to make an arthroscopic evaluation with probing of the posterior horn for all ACL tears. But what happens if we don't repair a stable ramp lesion? In this paper, we can see that there is no difference in terms of clinical outcome or resurgery rate, and that ACL reconstruction helps stable ramp lesion to heal. So they recommend to leave the surgeon decide according to the patient's profile and level of activity. And what about unstable ones? We can see in that case that neglected unstable ramp lesions lead to extension of the meniscal tear, more resurgery, ACL reconstruction failure because of the high stress on the graft, and knee osteoarthritis. And we can also see that the outcomes of the repair of the ramp lesions and stable ones are very good, with a high rate of healing around 90%, much higher than unrepaired lesion, and a very low rate of failure and resurgery. So the take-home message is to check the ramp in all ACL tears, especially when there is a chronic instability, pivot shift, and medial compartment pain. For stable lesions, we give the choice to the surgeon to operate or not to operate, but for unstable lesions, we have to repair them every time. Thank you.
Okay, thank you, Ahmed. We don't have any questions in the chat. So, Dr. Tborbi and Dr. Lafram, maybe do you have some remarks or?
No, no. I would ask the Dr. Papalia, do you use all inside devices for this ramp lesion, or always you use the hook?
Yeah, we do suture hook. Only inside, only with this kind of technique, using the hook.
The hook, yes.
Yeah.
Okay.
From posterior medial portal, using only one portal.
Yes.
And
because there is a technique also using two portal for the
two portals.
medial. Yeah, we use only one portal.
One portal,
and
like.
And are you repairing all of them or only unstable lesion?
Unstable lesion, but unstable lesion are very. You can detect often unstable lesion when you have the acute ramp lesion. Okay, because when you have the chronic, already also the outcome of your repair is not good as well as in the acute.
There is a question in the chat. How do you know if it's stable or not? The ramp lesion.
The stability of ramp lesion is judged with the probing from the anterior part.
Yeah.
Yes.
And mainly we consider it is unstable if it is more than 15 millimeter of large.
Okay.
Yeah, we published 6 months ago in American Journal of Sports Medicine study about the ramp lesion as reported in MRI in professional players with the lesion also of the semi-membranous part of the tendon. In this case, you have many problems with the football players with the rotation, and ramp repair is very important, as well as the use of the AL repair in this kind of patients. It's very important, the ramp lesion repair.
Dr. Papalia, you don't think that this type of medial tear are some apparent lesion of anteromedial rotatory instability, like tears of the deep MCL?
Yeah, I think so.
So for this patient, we have to do something on the medial side of the knee, not an ILL.
Medial side, and after that you have to prove the stability, and only after that you can decide to do also the LL. But I think the first problem is the medial aspect of the knee, medial side.
Okay. And you, in some case, you have to do for an ACL, a deep MCL and an ILL for the same patient?
Yeah. ACL?
Okay. ACL, deep MCL, and ILL reconstruction for the same patient. You did this for in some cases?
Yeah, depends on risk factor. It depends on the sport of the patients also.
Okay.
Omar, what do you do for your ramp lesion? You do the technique with the hook?
In 90% of cases, only in repair with the posteromedial portal. Sometimes with one portal, sometimes I do the two portals. But in 90% of cases, I will do repair.
Okay, it's an important stabilizer of the knee,
Yes.
so we have to repair it.
But it's more important to explore all the posterior part of the medial meniscus in all the cases of ACL reconstruction, because in sometimes we don't see the lesion on MRI.
Yes.
And
okay. Thank you, everyone.
I think
Yeah,
we have finished.
sometimes there is a scare that if there is the chronic lesion, you have a scare that but is something's not stable, and then you have to detach the scare and to do the repair.
yes,
Yes.
it's to make debridement of the scale before repairing the lesion, because when the
Have a
lesion
better healing.
right, so
Yeah.
all the scale is mask the beginning
lesion.
of the lesion. Yes.
We still have 5 minutes if you have any questions or remarks.
There is a request from Dr. Abdel Majid, Abdel Hamid, regarding sharing these videos on your Sotcot YouTube channel or platform.
Yes, it will be done. Don't worry. It will be done and it will be shared on our website, and there will be a link to the YouTube channel with the recording of this session and all the sessions also.
One question for Dr. Papalia about the same question of Anis Bourbi a few minutes later.
Go.
You go. You do the in cases when we do the reconstruction of ACL reconstruction and reconstruction of the deep MCL, you do the LAL to protect your ACL reconstruction, or because to control the stability?
This is a good question. Yeah, for me, it's most important to protect the ACL in high-risk patients. And then I do this kind of procedure to protect the ACL. Because for that, it's very important. Because if you do well deep ACL and ACL reconstruction, you are enough. But I think that using also the LL, you have a good protection of the ACL in high-risk patients.
Thank you very much, Dr. Papalia. I think I will leave the final words for Dr. Bouzidi to
I would like
conclude.
to thank all the participants to this meeting, and it was very, very, very interesting. Thank you so much for our guests from Italian Society, Dr. Papalia. It was very interesting. It was great talks and presentations. Thank you for all our speakers, Dr. Benamor from Tunisian Society of Arthroscopy and Sports Surgery, Dr. Bourbi, Dr. Lafram, Dr. Abid, thank you for preparing this session, and meet you for the next session. It will be on 1st March about cervical spine injury. And thank you so much, Kartasis Limurteni, and see you next Monday orthopedics meeting. Thank you and
Could you
goodbye.
please open your video to catch the selfie
photo?
Take a selfie.
With the smile, huh?
You tell us when it's done.
It is very interesting day for me because it's my birthday.
Happy birthday.
Congratulations.
Thank you.
Congratulations.
Happy
See you
birthday.
soon. Ciao, ciao. Bye-bye.
Bye-bye.
Yeah.
Bye, bye-bye.
Bye-bye.
Ciao, ciao.
Goodbye.
Bye-bye.
Thank you.
Thank you.
Bye,
Send the
Bye-bye.
photo.
Thank you.
Thank you.
Bye-bye.
Thank you. Thank you very much.
Thank you very much.